Presentation. Oh, and now we're recording, so it's official. I'm Sheila Squire. I serve on the Women's Fund Advisory Committee. The Community Foundation's Women's Fund is a field of interest fund created to improve through purposeful philanthropy the status and quality of life for women. Many of you may know of us from the Women's Fund grants that we make to nonprofits on an annual basis, but you might not be familiar with our objectives, of which we have 4. They are to promote educational, economic, social, and political equality for women, to enable women to achieve economic self-sufficiency, to ensure that women have the necessary resources for healthcare, and to honor our local women who have made our community a better place in which to live. Today's presentation actually responds to that first objective, and we have had a number of educational programs on different topics in the past. And we continue to strive to provide topics and information that are timely and help to move our local women forward. We're really excited to bring this opportunity to you today, and I will now pass the baton to Courtney Owens, also a member of the Women's Fund Committee, who will introduce our speaker. So take it away, Courtney.
Thank you, Sheila. Welcome, everybody. My name is Courtney Owens, as Sheila said, but to introduce Dr. Susan Salahshor, who is the founding program director of the Physician Assistant Program in the School of Health Sciences and Human Performance at Ithaca College. She has been a physician assistant for 25 years with experience in approximately 10 specialties. A 1994 graduate of St. John's University, Bailey Seton PA program. She has worked at Catholic Medical Center in Queens, New York, Cleveland Clinic, Florida, and Mayo Clinic, Florida, and in private practice. A mental health first aid instructor, Susan is certified to teach the adult higher education, military, and service members. 3 years ago, she and a PA student obtained a grant to teach mental health first aid to PA students across the state of Florida. She was one of the top producing hospital instructors in the Jacksonville Nonprofit Hospital Partnership Collaboration for Mental Health Training. Dr. Susan Salahshor is passionate about leadership development, advocacy, and community engagement. And I present to you Dr. Susan Salahshor.
Good afternoon, everyone, and welcome. Again, so happy to be here and to have this conversation with you. I'm choosing that word on purpose. This is a conversation because I do want to hear your voice. We're a small enough group that I think if you put in the chat, why are you attending today? That will help me. You can send it directly to me or to Courtney. She's monitoring the chat, so probably send it to Courtney because I'm trying to make sure I stay looking at the camera. But really wanting to know what made you come to this conversation today during Women's History Month. So I can make sure I touch upon the areas that are really critical to you. The Women's Fund has given me some breathing work to do in terms of I can go the depth and breadth of the direction I want to go in. And this is about health equity as it relates to women. And I will try to tie it in as much as possible in a global way as a woman who's from Jamaica and really understand what it is to have healthcare outside of the United States versus inside of the United States. So let's get started. So here, I wanted to, because I'm an educator, as you heard, talk about why are we here. So as we think about women in our life, we want to honor the historical contribution of those women. And I'm talking about women that are famous, and I'm talking women who are really famous, like our grandma and our moms, right? Because to me, they're the most famous because we have the relationship with them. But how can we honor what they stood for, their legacy during this month in a different way than we do all year long? And it's also to remind us of those who came before us. What work has been done to really move women forward in the world? And how can we make sure we honor those relationships? How can we make sure we honor those sacrifices that were made, including death? And then to engage us in a conversation around galvanizing, advocating for ourselves as we move forward from today onward, and being intentional about that and not taking any crap from anyone else. And yes, I said that. We need to be more aware of our responsibility to ourselves and to the generations that are coming behind us and be intentional about that work. So today we're going to talk about health equity. And when we talk about health equity, it's going to be health equity, health disparity around women issues across the globe. And we'll talk a little bit about definitions so we're on the same page. So here's what health equity is. The state in which everyone has a fair and just opportunity to attain their highest level of health. And then fair, because we want to make sure we understand the words that are in this definition, is we really try to move all that self-interest away. So when I'm advocating for health equity, I want to be fair across the spectrum, and I want to, at best, mitigate the biases I know I have and address them if I need to in the moment, and take ownership of that, right? So that does take some cultural humility around that topic. And then just, are we making sure what we do is morally good and upright? And so that is sometimes a piece that I think people forget in this definition. What is morally right for those that we're impacting? And the way I describe this to folks is, as a healthcare provider, one of the things I do with every patient I encounter, especially a patient that may be difficult that day for whatever reason, right? Because patients come into the hospital, they're sick, they're not at their best. I've been a patient, I'm not at my best. But how do I make sure I treat that patient like my grandma Olive? Because if I remind myself that my grandma Olive is the patient, my whole attitude change, my mannerism change, my patience increases. And so really trying to think distinctively of how I'm going to engage with that patient. And I'm going to pause here, Courtney, because I see the chat lighting up on my side. Is there any comments in there that we need to address?
No comments at the moment. Folks are interested in a number of reasons in terms of structural healthcare barriers when it comes to inequities. You've got some people who are interested in reproductive justice locally and internationally. You've got some individuals who are just excited to learn more. So we'll keep it there for the moment. Yeah. And thank you to everyone who's
right. I do have another talk coming up. I can't remember if it's next month around reproductive justice. So I don't want to take away from that show, but we will talk more about that. That's coming here in Tompkins County. So I want to pause here. And I want us all to take a deep breath. Maybe lower your gaze if you identify as a female. And I want you to reflect on an experience you had in your life that, as you think about it being Women's History Month, it comes to you. And there might have been a challenge with this experience. It might have been a great experience. It might have been a negative experience, but it has stayed with you. And as you think about what we're talking about today, I want you to think about that experience. And this is where I'm going to ask you, if you want to share that experience, you can put in the chat to me privately, and then we'll talk a little bit about it if you're comfortable sharing as well. So if you're comfortable sharing, I'm going to ask you to raise your hand and we'll get to you. And if you're not comfortable sharing, you can send it to me directly in this case. Okay. So lived experience. The picture on the right is the woman in the black dress and the blue jacket is my grandma Olive. This is the woman, third grade education, growing up in Jamaica, got pregnant when she was 16 years old. Her mother told her she couldn't live with her anymore, and she went to live in the fields of her home in Jamaica. And when her then boyfriend mother found out, we call her Gangang. When Gangang found out she was living in the bushes, she told my great-grandfather to go and get her and brought her to Kingston, Jamaica. We live in Kingston, and she was living in the country. Her last grade in school was third grade. She doesn't read well. And she came to this country when my mother filed for her to come and live with us. She's been a caregiver. She suffered heart disease. She suffered atrial fibrillation. She suffered menstrual bleeding, and you'll see how this connects. She suffered poverty, and she's lived in a country where women were not always honored in the way they should. She was the matriarch of her family. I come from a family where my father had 11 children, 2 of them with my mom. And so my mom was a single mom. The lady in the yellow is my mom. And I tell people she's my heart. She left Jamaica when I was probably about 8 to 10 years old. And she left because my grandmother Olive told her she needs to go to America for opportunities to help her children. And so my mother migrated here, and we did not see her for several years because she came in on a visa, stayed illegally, and then married her friend who lived in Jamaica, who became our stepdad. So reflecting on that. My mother suffers from heart disease because it's a family thing. I also have high blood pressure. She also has had a cardiac event where she lost consciousness for 10 minutes and 33 seconds, and I resuscitated her. She now lives either with me or my sister full time because she is afraid of living alone and having that event occur again. She has worked 3 jobs as a single mom to support her family, and she continues to support her family by helping us with our children, our grandchildren, and in some cases, great-grandchildren. That is me on the right. I migrated to this country when I was 15. The only time I saw a doctor was to get vaccinations. It was a doctor who worked out of the back of her home. I don't know what getting a regular physical looked like until I came to the United States. The only time I went to the doctor, and we had a doctor, they don't have PAs in Jamaica, was to get vaccines. And if you were sick and needed stitches, same doctor did all of those. And the little one in the front, she's no longer little like that anymore. She's 13 years old. That's my daughter, Savannah. She's my youngest child. I have 3 children. And she has asthma. And she's multiracial. Her dad is Puerto Rican. And again, I'm Jamaican. And so I share that with you because I want to give you a reference of the stories that I may speak to and let you know I can speak to some of my experience as a Jamaican, as a woman married to a Puerto Rican military man, and as this family who's gone through health crisis in and out of the United States. And that on the left-hand side is my pride and joy. And I put this here because it had 4 of us in here and I wanted to kind of give you a picture. The one on the far left is my daughter, Julie. She's 38. When I met her dad, she was 5. And then there's Savannah and getting the little one. She's now 6. That's Sloan. She's our princess diva. And all 3 of my Sloan, Julie, and Savannah have asthma and airway disease. So think about lung infections and risk. So wanted to share that with you. I'm pausing because now I'm looking in the chat to see if anyone has shared. All right. Okay.
We've got a question. Someone raised their hand, Mr. Brian.
Good afternoon, Jabron Haygood, youth advocate, worker at Family Children Services. So I was looking at the question in the box, and so mostly my experiences in my youth going to the hospital or in the healthcare system, I've been relatively fit since then. But just what kind of sticks out for me are those that have and those who have not. I was coming out with a Medicaid card, so often I was sitting in a waiting room for hours. For those that that had the Blue Cross Blue Shield or had the better insurance that I had, they went, of course, first, and it seemed like they were getting better treatment. They were getting better customer service. I mean, it just wasn't just with the doctor. It was all around customer service, entering into the hotel. Into the hospital, right from customer service. And that really just really sucked for me, right? Because I was poor, but it was no fault of my own. I was born into a poor family. And it just really stuck out to me that those that have and those who have not are treated very differently, all the way from customer service right to the healthcare you're getting. And usually, doctor kind of runs you off, pushes you to the side, don't really listen to you as they are listening to those who have. And it sucks.
So Jabrian, did I say that right? Because it's not Brian, it's Jabrian, right?
Jabron, the I silent.
Jabron.
Yeah.
Thank you for sharing. And so as you reflect on that, and this is not for you to necessarily answer right now, think about what, since then to now, what can we do to not make that continue to happen, right? Because you're obviously in a different space now, but as you think about health inequities the gaps we have. What can we do as a community to change that outcome? And this is part of the conversation we'll have, because I am a huge advocate. My grandmother, because she worked in Jamaica, did not have insurance and was on Medicaid. And I know there were times we couldn't get into a provider with her. At one point, I did pay for her insurance, but it got so expensive that someone said, you really need to get Medicaid for her. But I hear what you're saying, because I saw that experience that she went through. And in many cases, Medicaid is a resource for low-income individuals and for children. But what we have found is, because of how much the government pays and the lack of expansion of Medicaid, people are not addressing those issues because they go, I don't want to get paid at that level. So how do we as a community come up with ways? How do we get grants? How do we support change in the laws? And we're talking about federal law now, which is a whole different ballgame from state and local law. But how do we do some intentional work around that in different ways? I know for me as a healthcare professional, we're doing a lot of work around Medicaid and mental health, to say, we can provide this care, give us room to do that as physician assistants, and then try to figure out what other areas we can do that in. But thank you for sharing that, because that's an ongoing issue that we keep talking about. And I always say, I feel like we need to do something, but what is that something we can do that we can manage as an individual and as a community? I see Karen's comments. So thank you, Karen, for being here around the work you do. So please let us know if you have any questions, because we talk all the time. And then I have a couple of private ones that I'm not going to share the content, but I want to speak to them. When you have a provider as someone who identifies as a woman, and at any given time, they make the decision to not treat you in a respectful way, regardless of what it is, you are absolutely right. I support walking out. Walking out. Because that is part of the power of us saying, we're not taking any crap, right? I'm not taking this from you. I won't tolerate this. And we have to stop having this, feeling of, I don't want to upset the apple cart. I don't want to be angry. I don't want to be rude. This is our body. It has been given to us. We need to honor our bodies and don't let anyone abuse our bodies, even in how they engage with us. And so for the person who shared about the pelvic exam, I don't know if I would have been that nice. I might have had to take my earrings off, but that's just me. But I probably would have called someone in that moment and dealt with that decisively, because then I think about who else is coming after me and what are they gonna do? But when you go through trauma, and that is the other piece that people sometimes forget, when we have a bad experience with any provider, any system, that is traumatic. And we may go into shock, we may go into fear or that protective mechanism, and it sometimes makes us unable to respond. This person responded and did something about it. And that's what we need to do. We need to continue to engage in making people take ownership of bad behavior. The second one that, again, this is private, so I'm just putting it in a way that you cannot identify the person. I'm talking about performance review and tone around being a parent. How do we parent in an area, parent in a culture that says you need to work, and don't honor your parenting? I'm a no nonsense kind of person around these conversations, and I'll sometimes say to people, so this is my lived experience. This is what I need to do today, and share with them on the front end. So when they come up with, around my performance on these topics, I go, maybe we should both meet with HR and have a conversation about how you're potentially invading spaces you shouldn't be in, because I am not going to be an effective worker if my whole being is not being addressed. I gave an interview yesterday around this topic of the whole person, and part of it being physical, emotional, social, intimacy, sexual, and financial. Those 5 things, if anything is out of sync, it's going to affect us in some way. Usually it's physical. So we really have to be cognizant of our responsibilities to ourselves and not letting others define what that looks like. And sometimes that's challenging, because as women, again, I know for me, I don't know about anyone else, give me a thumbs up or something, where when you get angry, you start crying. And then you start crying, and then people say you're emotional. And then you start crying more because you're mad that they said you're emotional. And now you can't have impact because now you're really emotional because you're so upset, and you become a little bit ineffective, if you will. But usually when I do that, see a thumbs up, I just go, you know what, this is just one of those days. I'm gonna give myself some grace, and I'm gonna fail forward, and it's gonna be okay. But we have to be okay with that. We have to be okay, because think about how someone who identifies as a male, how they express themselves. They express themselves in some way. Is it called the same thing we're called when we express ourselves? So really taking ownership of, we're not going to tolerate the bad behavior, and we're not going to have you talk to us any which way you want to. All right. George, tell me if I'm back on the right slide.
You're on the question slide right now.
Okay. Got it. Stop sharing. All right. George, if you can get ready to put my slide up, I think that's going to be easier than me switching in and out, because every time I go into this mode,
Yes.
it's moving things. And
Okay.
I have too many windows open. I have 3 screens, everyone.
3
Let's
screens.
see.
Which
I'm
slide
looking
would
at
you like
some-
to be on? I'm sorry.
I
Which
would
slide
like
would
to
you-
be on slide 6.
Okay, I can get us there.
All right. So here, these are 7 facts. I'm seeing the comments in the chat, by the way, and I'll continue to incorporate them as we go along. So don't think I'm not watching the chat, and I will respond to some of those. Just put the chat on this side so I still have it in front of me. All right. Here, this is information that is from the Center of Disease, CDC, prevention. So really, Center of Disease Control, sent 7 facts to consider in the health of women. These are here because it's a reminder to us that we need to really think about what impacts a woman. So caregiver, many of us, not just women, men are caregivers. But in most cases, women are the primary caregiver. In part, when you think about partners, women live longer than their partners. So when you're given caregiving to others, you are at risk for physical unwellness, mental unwellness, and just really trying to take care of someone, take care of yourself, plus take care of the kids, do your job. It's a lot of burden on women that then has physical health consequences. And this is across the spectrum. We found this based on the work, because many women who go out to work also feel responsible for the home, and whether that partnership is not quite even, how do we get it to be even so we take care of each other? Studies show that women who have physical disability are more at risk for certain intimate partner violence, for health issues, and in part because the burden of having a physical disability, that when access is not always available, that creates emotional stress. That may lead them to do something they physically should not do because it will be unsafe for them, but they try to do that. As you think about outside of the United States and beyond, not just in the United States, but outside as well, menstrual hygiene. Do women have access to products for menstruation? Do women have a private place to take care of themselves during their cycle? And do women have access to medications that they may need during that time? So that's where this piece is kind of going to. And then this next one is about bleeding disorders that are seen in women and what happens when we need to have them taken care of. And so some of the comments I'm seeing in the chat relates to some of these things, in the sense of, these are the issues I had. I went to see a provider and here's my experience. And I am still, I have conversations now with providers where we talk about healthcare providers say they will do no harm. But we do so much harm, and then we say, well, that's just me being a provider. I need you to be a human being first. And so for those of you who have shared in the chat about your lived experiences around healthcare providers, I challenge you to say to that healthcare provider, would you treat your mom, some female in their life this way, or some person in their life this way? And then usually that's a good way to reset people with bad behaviors. So how would you treat someone if they were this? Remember what I said to you about my grandma, right? I always go back to that. And then sexually transmitted infections. Lots of research around women getting sexually transmitted infections from intimate partner violence, rape, incest, all those pieces coming into play. In many countries, women are not allowed to use protection, whatever that may look like. And so they're at risk for all these things happening. As you know, intimate partner violence, I mean, we really saw an uptake during COVID, really brought out some of the issues people face in general around intimate partner violence and decisions that are made. I took care of a patient several years ago, did not come to me because I never worked in the emergency room, but came to me for some other medical issues, was in the hospital, and was a battered woman at home. And as we were talking, I said, I just want to have a conversation with you about what's keeping you there. And one of the things was she had quit her job to take care of the kids. She didn't want the kids to be hurt in the process and not have a place to go. She didn't want to go to a homeless shelter, and that was the only thing that was offered to her. And so here she was sitting in this environment with violence in the home, probably having lots of issues around being a caregiver in terms of taking care of her children. And she was not willing to leave this individual because of her children. So lots of mental health tying pieces to this, physical health, because we know hormonally when our stress level goes up, it in fact affects our hearts, our lungs, and all other parts of us. And then substance use disorder, and we'll talk a little bit more about this when we talk about heart disease and other pieces of what we see in women in terms of mortality, meaning what do women die from or at risk for? And substance use disorder, especially around opioids. There are studies that show women are given more opioids for pain because we think it's pain and not really treating what is really wrong with a woman. And so really trying to figure out how do we have that conversation of, I need something for pain, but does it have to be a drug that has potential addictive tendency, or could it be something else? Is there other options available that you could use for me? So Paul, I'm going to pause here and just look in the chat. As I'm looking in the chat, if you could stop sharing, George. As I'm looking in the chat, I'm going to ask if someone is willing to say, when you go to look for a provider, just in general, what's the thing that makes you pick a provider? Anyone? What typically, I think I know the answer, but I just want to give us some frame of reference. What's the thing that says, I'm going to go to this provider? What do we use?
Heart.
Say that again?
Heart.
Heart. So you go to the provider for your heart.
No, for their good heart.
For their good heart. So you like them.
No, that they're empathic and care about me as a person.
Okay, so they're a kind provider. So that's one of the reasons. Is that your number one reason, Melissa?
No, expertise is number one.
Okay, so Melissa's number one reason is expertise. What else?
Compassion.
Compassion. Mine is insurance, but who else? Anyone? Do they take my insurance?
Yeah, I was gonna say insurance as well as referral. Someone who's been there before, who's had a good experience with them. That means a lot.
Yeah. Someone put it in here. Someone said they take my insurance. Good, good experience. Age and gender. I like that. Age and gender.
I have lived in this town for 43 years. I've never been able to find what I want in a practitioner, which is another gay man. There's no out gay male practitioner in this county and hasn't been for over 40 years. But I'm also looking for someone that's going to generate options and not take over control. The final decision's mine, not theirs.
Yeah. So understand what shared decision means and doesn't mean.
Mhm.
Yeah.
I was gonna say reputation. I get my services in Rochester just because I've been there and it's just they have a better reputation. They have better services. They're world known, and so a lot of times I know some folks will go out of the county because of the reputation that's here.
Mhm. And Jabron, can you tell us a little bit about that reputation? Tell me what you mean. Are you saying it from an identity standpoint that you don't feel they take care of people who? Are you saying it?
Well, what I mean by that is not only identity, just the all around general care.
Okay.
You know, I've seen them poke trying to get blood and just like poking you 5 times. There's no compassion for that. It's just really not a very, my take of it is just not only identity, but also the reputation and the service that you get currently at Cayuga Medical. That's why I go to Rochester, and a lot of folks have had a big problem with Cayuga Medical Center, especially people of color.
Yes, okay. So we need to get you to talk to Herb Alexander. I've written your name down. Courtney, make a note and send me an email. I'm going to connect to Herb Alexander because we need to make that change because Cayuga is one of our partners and they've been working with us. Herb has come in and given lectures around health equity to our learners. Dr. Dundale and him came in and talked with our learners and said, if anything is going on, let us know. So far, their experience has been good. And I know Cayuga has made significant changes now. And I will say, I'm not saying not to go to Rochester, but we may have had a bad experience and we need to continue to have those conversations. And even if you choose not to come, this particular video that I've had the opportunity to watch really shows that they know they have work to do and they're trying to make that change. So thank you for sharing that. George, so I heard what you said. So then how do you pick a provider as you think about you can't find a gay male identifying in Ithaca to take care of you? What else do you then use to make a decision?
Someone who's willing to be educated by my lived experience. It's typically been a woman.
Okay.
I don't find that straight men are as open to engaging in that conversation.
Okay, thank you for sharing that. Marie?
So I look for someone who will listen. It's very important that the provider listen to me because I'm an atypical patient. For instance, blood pressure that's acceptable and seem normal in a regular patient is high blood pressure for me. A systolic of 83. I'm symptomatic with that. And it's very difficult to find providers who will listen to me on that, knowing that I am suffering with that. I'm sorry, diastolic.
I was gonna ask you the question because I was like, if you have a systolic of 83, we might need to have a whole different conversation on.
Yeah, I'm sorry about that. Yeah, a diastolic of 83, I'm symptomatic, and when it gets to 90, I'm literally dying. I need something for my heart, and so it's important that somebody listen to me because I'm atypical. And I will change a provider in a blink. I usually have to advocate for myself and, to get a medication if that happens to me. And I'm sitting in the office, they're like, oh, you're fine. It's not so bad. Oh, I'm dying, and recently it went to 160s over 90s. And they had to give me, what do you call it? I can't think of a medication that brings it down immediately. Oh gosh, what's put under my tongue?
Tip of the tongue phenomenal. We'll come back to it.
No, I'm saying the one you put under the tongue.
Oh, is it clonidine? There's a few under the tongue.
Because I have chest pain with it.
Okay.
Also.
Nitroglycerin.
Nitro. Yeah, there you go. Thank you.
The chest pain was a clue.
Exactly. So so it's important to have somebody who listens.
All right, so listen, identify with our sexual identity, insurance. Let's see in the chat, I see age and gender, experience. I look for a woman. I am very specific about that now. As a woman, I look for a woman provider in every area of my life. And I choose to do that now because I do have insurance that allows me to do that. And so I feel like this is an opportunity for me to advocate for myself. My daughter goes to Northeast Peds, and I asked for a woman to see her because she did not want a male. So we have to be really thoughtful about that when we make a decision. And my therapist is a Black woman who takes my insurance. I'm on the other side of my life, and I need someone who looks like me that understands my lived experience. So I think about, George, if it was someone relates, that is one of the things. I don't have any stakes or what do you call it, stocks in psychology today. But what I love about psychology today is you literally put in your insurance if that's the primary thing for you. You put in your insurance. You can then say you want a male or female. You can then say what type of male and female you want, what services you want, and they will find something. And that allows you to pick someone that you can better identify with. If you have to pick a provider because you have no choice, you have Medicaid, you have Medicare or Medicare plus Medicare HMO for full insurance, then when you first go to them, have a conversation. See if you can call and talk to the provider, a nurse, or someone who's helping in the office to see what kind of patients they've seen. Look at the patient reviews. Those are available now. That's a great thing about living in the United States. We got reviews. When I was growing up, I had no option. If I was sick, whoever's willing to take us is who we're going to. And so we have the privilege of having choices in that way. But I didn't have a choice when I was growing up. If that doctor I didn't like that doctor, guess what? That's the doctor I was seeing because that's where my grandmother could afford to take us. And we went to the public hospital because we couldn't afford to go anywhere else. So think about, as we think about global needs, they're very different in many ways from our needs here in the United States.
Doctor, if I could just interrupt on that one point. A lot of folks who are on Medicaid or who doesn't have A-rate insurance are not very articulate enough to express those concerns. So that leaves a whole group of people out who are not articulate to get their point across. And so what do you do with that?
So what I'll say is, and I'm not putting the women's fund on the spot, but one of the things I do now is I will say to people that I know personally, if you're going to see a provider and you have concerns, reach out to me. And we can talk through some of the things that have come up. I'll talk to people who I'll say, after you see the provider, or can you call me while you're there? I wish that there are services like that, but again, it costs money, right? Because if you don't, I know a woman who, she was a healthcare administrator and she had seen exactly what you talked about. And she offered this service to people to say, when you're going to the provider, we will take you. And the people who did it were medical students, PA students, or health profession students. She would hire them, so she didn't have to pay a lot of money for them, but they would go with them to the appointments. Or they'd say, why are you going to the doctor or the provider? And they would write down and then I have a conversation with them. So what I will say is, I know this is tough to hear, but from my grandmother who had a 3rd grade education, we never sent her to an appointment by herself. Whenever she was in the hospital, we always had someone stay with her, included at nighttime. But I showed you a slide that talked about caregiver burden, right? So that's that balance and piece. But we felt as a family that we needed to be there for her. As I look at the chat, the other thing that comes to mind as I'm sharing that is we need more of us to be advocates for each other. If I'm sitting in the waiting room or I'm the nurse in the room and that provider is not given the standard of care they should, why aren't we saying something? Right? Because we can blow the whistle without telling them, just putting it out there, right? We don't have to be the one that identify right away. We have to advocate for each other because there are people coming behind us. So remember that first slide, right? Women's History Month. We want to honor those who came before, but we want to galvanize ourselves to move forward in the future. So that is one of the things that I do. And I'm here. I think I know who you are, but I don't know if you remember, you've met me. You know how to find me, and I'm happy to advocate. But I'm a huge advocate to say, if you need someone to be there for you. The other thing is, healthcare is changing. Nicole, I'll be right with you. Healthcare is changing, and healthcare organizations can no longer kind of say, this is how we always did it. I don't really care. It's different now. If you look at the Cayuga Health System, they now have where you can put your pronouns. And I'm very, very, very comfortable telling people I know to call the patient advocate and call administration and call whoever you need to call to have them advocate for you, at least address the issue so you don't feel like you're walking out of that space without the support you need. If someone has I just told our learners, our peer learners yesterday, if someone has a language barrier, they're supposed to provide a translator. It is part of the healthcare delivery model. So we need to stop and say, where's the translator? And it's not your person that, if I bring my 8-year-old or 10-year-old, they're not supposed to translate for me, just in case there's something I don't want them translating, right? So giving me that privacy in that space. Nicole and then Marie.
Yes, so I just wanted to put a plug here as we're talking about advocacy, especially when we're talking about working with health insurance, that here at Human Services Coalition, we have our Community Health Advocate Program. And this program is specifically designed to assist people, regardless of type of health insurance, in anything having to do with health insurance, including finding providers. And you can be very explicit in like, I'm looking for this type of provider. This is the insurance I have, and they will help you find those providers. They also will help with things like we had a Medicaid beneficiary who needed dental work, and the dentist told them, your insurance won't approve it. So our health advocate contacted them, and it wasn't that they didn't approve it, they didn't even put it through to see if it got approved, and it was covered. So because our community health advocate made that phone call, made that connection, because they have that knowledge, they were able to get that service they were otherwise not going to get.
Now, Nicole, I'm going to ask you to do us a favor. Can you put to everyone in the chat your contact information, or not your contact information, we don't want your phone blowing up, but maybe the contact information for your agency, because I think that's important for us to have. Again, thanking you all for giving me this opportunity for us to have this conversation and talk about things that we may not know exist in the community.
Yeah.
So please put that in the chat. The other, Marie, sorry.
Yes, thanks, Doctor. I used to attend church in Harlem, New York. And so I'm now living in Ithaca, and I have these friends whose 100-year-old mother needed some kind of service at home. And they felt that they were being railroaded one way to provide this end-of-life service for her, because the system, they assume, in the hospital that she went to, that she's going to die any moment now. So they needed some kind of advocacy. And what they did, they went to the doctor's office and they signed all the appropriate papers and allowed them to talk to me. And so I was able to advocate for her on the phone with them. Now, the question is there such an organization, or can we start something where we could be there for people, to advocate for them depending on what's going on? They can have our information, take it to the doctor with them and say, here, please talk to this person on my behalf.
Yeah. So it's organizations like what Nicole is talking about. It is, if you're in a hospital using the patient advocate office, there usually is a patient advocate office or patient experience. They call it different names, but it's really about the patient. If it's outside of that, I'm going to say, Marie, probably the best resource is to call the insurance company and see if there is options that are available. The other thing is use your community. Put in patient advocate in Tompkins County and see what comes up, right? So whatever county they are, downstate, I would say research that. So that's another way. There's some national groups that have local opportunities. So I know United Way, I think it's still 211. They sometimes will have resources available. There's lots of things that we could do, but I think we have to be careful about our bandwidth. I hear what you're saying, and I do the same thing.
Mm-hmm.
What can we direct people to, or how can we empower the patient to advocate for themselves? How can we empower that individual who's accessing the health system to make sure they get equity care, right? Equal care, right? Not equal, fair and just care, that they're getting the care they need based on their needs. So in this case, this provider might have been thinking equal care, they're 100, this is what we need to do, as opposed to fair and just care, they're 100, but they're doing really well. Can we address the problem and not kind of write them off? So really, part of that is educating people, but that is challenging. I see someone put in the chat about your level of education. It is challenging because if someone has a certain level of education, How are the reading material? I was told the reading material in most, and Karen Brown, if you could put a comment, I think it's 5th grade. I advocate, I would like it to be 3rd grade. Why? Why did I pick 3rd grade? Because my grandma had a 3rd grade education. And as a caregiver, it was overwhelming sometimes, you know, where we had to not go into work that day because someone had to be in the hospital with her, which means we're losing work, right? So all these pieces that then affect our social determinants of health and our family network or connections and how we take care of each other. So I think maybe, Sheila, I'm going to pick on you because I've met you and I haven't met Nancy. We can have something where Nicole and others like Nicole talk about the resources available in Tompkins County related to health and social determinants of health. Because I think that's a layer sometimes that we forget. What are the resources in our community that we can access? And how do we access those resources in an intentional way? And I'm happy to be at that event, Courtney, if it fits with my calendar. Someone put in here about cognitive differences. Yes. I want to talk a little bit about that. When someone has cognitive impairment, in my opinion, they should not go to a provider by themselves. Someone needs to be there with them, either to just write down information. If I was late for an appointment with my grandmother, I'd say to her, just write something that's gonna, don't worry about the spelling or anything, just write down what you want to make sure I talk to them about when I get there or when they get me on the phone. So I don't believe in someone with cognitive impairment going to the provider on their own. Whenever I call a doctor's office or a provider office, I should say provider because I'm a PA. Whenever I call a provider office and say, my grandmother saw you, blah, 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 and they give me like their spiel, I just stopped them and said, okay, let me rephrase that. Pretend I'm your mother, father, or whoever you love the most. And now I want you to answer my question, because it sounds like you're having a really bad day. And I get it, you work in a provider office, but I need you to help me with my grandma. Can we take a deep breath together and maybe try to help me? Silence on the phone. But 99% of the time they apologize because they've taken a breath and they want to help. So really, I will say the big picture in some ways is really the little things, because we need the little things to get the big picture to work. We also have to think about, if we're having issue with a provider, if we don't tell someone in charge, it's not going to change. If we don't tell someone in charge, they're going to continue to do that bad behavior and it won't change. I had an experience where my mom, when she lost consciousness, the cardiologist came in and just started talking, didn't introduce himself, looked at my mother, didn't acknowledge anyone else in the room, and began to tell us how great he was at his job. And my mother said, that's my daughter, Susan, and I want you to talk to her because she's going to tell me if I'm going to do this procedure or not. And my mom is pretty educated, right? She could have made that decision. And he said, well, I'm really good at what I do. And the cardiologist before, he doesn't do this procedure, but I do it all the time. I'm confident I can do it. Now, immediately by his body language and tone, so read your body language and tone of providers, is just read the body language. I realized, no, you have the God complex. You're not going to do anything. Like, I'm saying this in my head. I'm not saying it to him. We're at one of their hospitals where they can't do open heart surgery. And it basically is telling me a complication is she's going to need open heart surgery. We're 30 minutes from that hospital that they can airlift her to. And I said, I think we're going to have, we would like her to be transferred to your hospital that can do open heart surgery. And he looked at me and said, there's no need for that. Do you have a provider that's going to accept her? Wrong answer, right? Because immediately then, listen to what I just said. Do you have a provider that's going to accept her? If someone challenges you as a patient in that way, you probably don't want to see them anymore. Because what they're telling you is that they're not humble enough to know this is over their head and it is not the safest option for the patient. And if something happens, they won't stop and do the right thing in some cases. And the studies show, just so you're aware, I can say this to you as a healthcare provider, we still struggle with medical errors in medicine because there's a hierarchical system that says, if I'm the doctor, you don't tell me what to do. And if the nurse doesn't stop it and the tech doesn't stop it and the PA doesn't stop it, it still happens. We still have wrong-sided surgery, even though we've put processes in place. So that tells you people are still afraid. And what I will say to you is I empower you to not be afraid to get the best care for yourself. And if you're challenged to say, how do I do that? Think about if that person was seeing your child who could not make decision, or someone with cognitive impairment that you're a caregiver for and they could not make the decision. And that's how you're going to pivot. So really being thoughtful about that process of taking ownership of that. So Karen put in here 5th to 6th grade. We need to change that. So I keep telling Karen, I want to figure out how we're going to make it 3rd grade because I think it's important. Next slide for us, George. Great conversation. I was worried about time, but I'm probably not going to get through my slides, but that's fine. That's why I'm here. Next slide. All right. I just wanted to put this slide here. We will not dwell on it, but I wanted to show what causes death for women who are biological women. And this is the list. And as you can see, when you look at the United States and globally, lots of similarities here. All of these are related to those 7 things we talked about. They all come back to this, our exposure. What do we see and what are we feeling? So really trying to understand that taking care of ourselves is going to impact heart disease and stroke. Getting our mammograms when we should, on time. I like the system now. When I first came here, I didn't have a system where they immediately told me my mammogram result. They do now because the studies show when a woman has a mammogram or someone who was born with female organs has a mammogram, they are stressed out the whole time till they get the results about what the results are. So now they give us that information right away. Someone talked about cognitive impairment. I think about dementia. If someone is early cognition is really going down, what do we do to make sure we try to address that early rather than later? And this ties into some of those, like Marie talked about medication, having people explain what the medicines are. One of the studies I've been looking at, Dr. Mary Khan, I used to work with her at the Mayo Clinic, and she shared about in the orthopedic world, being an orthopedic surgeon, how she was treated and how she was perceived. And she talked about heart disease as it relates to like knee replacement and how the studies show more women were not getting knee replacements because they were telling them to do other things before they got to that. It's the same thing with heart disease. I share with people, women present differently with heart disease or cardiac problems. How do we make sure we address those issues and don't blow them off? Is really important in any kind of environment we're in. We have to listen to folks. Next slide. All right. We've talked a little bit about real cases, so we're going to go to the questions. How are we advocating for our health? Because I see we have about 8 minutes and I want to honor your time. How are we advocating for others impacted by, that should be by, that's missing a Y, the social determinants of health? So I'm talking about economics, where they live, rural, sexual identity, finances, do they have insurance, don't have insurance, all those broadband, do they have internet? And where do we go from here locally, regionally, nationally, and globally? Thank you, George. We can stop sharing. All right. Now, what I will say is for me, as I look at those questions, I'm a huge advocate. I am focused very much on locally right now, in part because I run a PA program. I have PA learners, I call our student learners. And I want to really try to, number one, get them to embrace Tompkins County and the region and consider staying here to practice. So I'm very focused on local advocacy and what that looks like. So Brian, that's why I work with Cayuga and I let them know any issues I'm having. I'm very comfortable saying to people, I won't tell you how to run a practice, but I'll tell you how your practice is creating barriers for me to seek care there. I won't tell you how to run your practice, but I'll tell you the barriers they're creating for me, a Black woman, to get care there, or my daughter to get care there. And that is where I go. So if you think about how do you recognize yourself, that is what the conversation we need to have. And if you're uncomfortable, I'm happy to do a coaching session where I tell you how to have the conversation. And if it's Cayuga, I'm sure someone from Cayuga is going to be listening to this if they're not here, but I will be reaching out to Herb Alexander and Sheila. I'll copy you on that email about potentially what Cayuga needs to do in terms of engaging with your audience. So with that, I'll pause and see if there's any questions. I forgot what we said and we were going to do at this point. So I just want to Any final thoughts? Did anyone feel like they didn't get what they needed today?
I
am
want
going
to, on behalf of the Community Foundation Women's Fund Advisory Committee, our board and our staff, Dr. Salahshor, I want to thank you for taking time, for being real with us, for speaking with compassion, integrity, optimism, and strength of purpose. These are all skills that we all can bring to bear on our engagement in the healthcare setting. When we talk about community foundation and community philanthropy, we talk about philanthropy as everyone's great joy and obligation to be involved in the voluntary contribution of 5 T's: time, talent, treasure, testimony from a variety of lived experience, and ties, our relationships with each other. In the optimistic goal that as good as things are, or as much change and improvement we need to see, we can all do this together. And you've given us a lot to think about and a lot to be proud about. And we're really excited and happy that you've joined with the Women's Fund and that you're part of our community and that you're making such an impression in our community with this lovely downtown facility right behind you. For folks that don't know, can you just speak a moment or two about the presence of your program on the Commons?
Yes. If I didn't answer your question, because I see some in there, put my email address and my cell phone, please reach out to me. I was focused on health equity and women. So some of the things you might have wanted me to pull out, I tried to, as I talked about my own lived experience. But if you're not fulfilled on that, I didn't kind of check the objectives off, feel free to email me or text me and say you attended and you wanted to have a further discussion. And I'm happy to connect you with the individuals who are doing the reproductive talk that's coming up. I cannot remember right now, Stacy. So just send me an email or send me a text and I'll forward that information to you. It's in my email. So the PA program has an instructional site. We're part of Ithaca College. We spend the first semester, our learners spend the first semester on main campus when they start with us, and then they come down to the instructional site. I'm happy to give a tour if someone wants to. The reason we are down here is they needed adequate space. We had 30 learners in the first class, 40 in the class that's downtown now. The first 30, you might have seen them out in the practice. They're in Cayuga Health System and surrounding communities, taking care of patients. And so you let me know if they're not behaving themselves, I'll address it. But I hear they're doing amazing work. And our third class will start in the fall and there'll be 50 learners here. We are one of probably the top 5 to 10, if not in the top 5, for a predominantly white institution that's created an inclusive environment in our program and across our campus in many ways. And I'm not saying we don't have issues, but we've created a sense of belonging for underrepresented minorities in medicine to allow them to come here and feel like they are supported so they can give care to reduce some of those racial inequities. Because when we see somebody who looks like us, identify as us, we know that changed the delivery of healthcare.
Thank you so much. And thank you to the Women's Fund. I want to encourage people to learn more about the Women's Fund and all of the Community Foundation. This is our website, cftompkins.org. And we have a lot of events, and this is our event for today. We have a whole calendar of events. An event coming up in April is around civic engagement and getting people registered to vote and talking about voter participation. So the Community Foundation is able to make grants. Last year we made about $2.8 million in grants, over 700 different grants, thanks to the generosity of donors like you, and appreciate all that you do to learn about what's going on in our community, to engage in what's going on in our community, and to support and to advocate for each other. Sheila, any last words, or Courtney?
Just thank you, Dr. Susan Salahshor, for being a great friend and for doing this. This is my first opportunity to serve in this capacity, so this is great, and I appreciate you for taking the time out.
And Courtney, in addition to being a member of the Women's Fund, is a member of our class of 2023 brand new board of directors here at the Community Foundation. We're very excited about that.
Have a good day, everyone. And again, feel free to reach out. Take care. Be well.
Thank you.